This week's video, we will be focusing on diabetes. Specifically, in this video, we'll focus on type 1 diabetes. But before we can discuss what goes wrong in the body that leads to type 1 diabetes, we first need to understand the insulin signaling cascade. Now, insulin is a peptide hormone that's produced by the beta cells of the pancreas, which I am showing you here. And it leads to a variety of complex downstream effects that are related to the regulation of metabolism. And the effect that we're going to discuss in detail in this video that will be essential for understanding type 1 diabetes is going to be our blood glucose regulation. Now, pancreatic beta cells are sensitive to systemic blood glucose concentrations, and in the presence of high blood glucose levels, like after a meal, glucose will enter the pancreatic beta cells through the GLUT2 or glucose transporter 2, which is found on their membranes. So this glucose is then phosphorylated and fed into mitochondrial pathways, leading to the production of ATP. And this causes an increase in the ATP to ADP ratio in the beta cells, and this increased ratio leads to the closure of these ATP-gated potassium channels. And this is going to lead to a buildup of potassium inside of that beta cell, which will eventually lead to depolarization. This depolarization is going to trigger the opening of these voltage-gated calcium channels, allowing calcium influx into the beta cells. And this is going to lead to a further downstream calcium release from intracellular stores. Once this cytosolic calcium reaches a specific threshold, the previously synthesized and stored insulin in vesicles or granules will undergo exocytosis, releasing insulin into the systemic circulation. This insulin is then going to travel to its target cells in either the hepatic, adipose, or muscle tissues, for example, where it will bind its insulin receptor, which has tyrosine kinase activity. This binding of insulin to its receptor is going to lead to the autophosphorylation of the insulin receptor's intracellular regions and the phosphorylation of insulin receptor substrates. Eventually, this is going to trigger that signaling cascade that's going to lead to the insertion of, now we're talking about GLUT4 or our glucose transporter 4 into the membranes of our target cells. Now these transporters are going to allow for the entry of glucose again into our target cells from the systemic circulation to either be directly utilized or be stored. This entry of glucose into our target cells will lead to a reduction in the blood glucose levels, which will limit the glucose entry into the beta cells and begin slowing down this insulin release, because this insulin surge is no longer needed because we've gotten all the glucose into our target cells that we need. Now, keep in mind that this happens in response to food, for example, but there is also a basal amount of insulin released to help control blood glucose between meals. So keep this in mind because we will revisit this later in the video. So moving to the next slide. So now that we understand insulin release from beta cells and the signaling cascade triggered by insulin on its target cells, let's discuss what goes awry that leads to type 1 diabetes. So we'll move to our next slide. Now, type 1 diabetes is an autoimmune disorder that leads to the progressive destruction of pancreatic beta cells. So it's thought that some sort of initiating event leads to the recognition of pancreatic beta cell related autoantigens like insulin itself by immune cells, which inappropriately mount an immune response against the pancreatic beta cells through different immune cell types like T cells, or following recognition by autoantibodies produced by B cells. And these autoantibodies are used to diagnose type 1 versus type 2 diabetes. So the immune response leads to the destruction of beta cells and eventually an absolute insulin deficiency. And this will lead to the signs and symptoms of hyperglycemia, like polyuria, polydipsia, and polyphagia, as well as an elevated A1C. So moving to our next slide. So now the only way to correct this absolute insulin deficiency and provide a way for type 1 diabetics to manage their hyperglycemia and utilize glucose in their target cells is by exogenous insulin administration, which will be able to trigger that same sort of cascade that we discussed earlier with endogenously produced and released insulin. So moving to the next slide. So now there are a lot of different insulin preparations available on the market, and choice of insulin regimen will be based on a number of pharmacologic considerations and patient-centered treatment factors. So on the next few slides, we will go through some examples of these and ways in which you can organize these different insulins to help you with your studying, but also in a way that will help you come up with insulin regimens to suit the needs of type 1 diabetics. So moving to our next slide. So before we dive into insulin types, let's first talk about physiologic glucose and insulin concentrations for non-diabetics. So these concentration time curves will look a lot like this if they are eating 3 meals a day, where the insulin graph follows very closely to the glucose levels, where it spikes with meals but remains steady in between meals and at night. And we need this basal insulin level so our bodies can utilize glucose throughout the day for normal functions, and then these postprandial spikes to use the glucose from food to be stored for later or used immediately and avoid hyperglycemic episodes. Now, type 1 diabetics have this absolute insulin deficiency, so we need to supply insulin in a way that will mimic both the basal and the prandial or mealtime insulin release depicted in this graph to ensure glucose utilization and prevent hyperglycemia and downstream complications from prolonged hyperglycemia. So now let's talk more about these insulin types on our next slide. And we will start by comparing insulins based on their pharmacology, and then we will go over some patient-centered factors along the way and at the end. So first, for comparison's sake, we have endogenous insulin, which will be the quickest on-off switch. And this peak is what we want to mimic as closely as possible from whatever mealtime insulin we choose for our patient. Now, our rapid-acting insulins will be the insulins most closely mimicking physiologic insulin release following a meal, where the onset of action is about 15 minutes, the peak occurs at about an hour, and they last about 3 to 5 hours. And these rapid-acting insulins would include insulin lispro, glulisine, and aspart. Now, our next option for mealtime insulin is regular insulin, which is short-acting, and this one takes about 30 minutes to an hour to start working. We see the peak at about 2 to 4 hours, and it usually lasts about 6 hours. Now, patients will have less flexibility with this short-acting insulin, and will really have to plan their meals and their insulin doses out accordingly to ensure the insulin is given at the right time with sufficient time before a meal. Otherwise, the patient will experience dips and spikes in their glucose levels. Now, moving into our intermediate insulins, which is known as NPH insulin, and this can fit the role of basal insulin, but it is not the best option necessarily for this. So NPH has an onset of about 2 to 4 hours, a peak at about 8 or so, and it lasts about 14 to 20 hours. So remember, under normal conditions, we always have a steady level of basal insulin. But with NPH, we are actually not covering the full 24-hour window with one dose. So this will either require 2 doses, so 2 injections, in addition to some likely mealtime insulin to cover the full day. So to circumvent this issue with intermediate insulin, like NPH, we have long-acting insulins like insulin glargine, detamir, and degludec, which each have an onset of about 1 to 2 hours. They don't really have a peak. You might see one listed occasionally for like 8 hours. and they can cover the entire day with a duration of 24 to 30 hours, and in the case of degludec, up to 42 hours. And these long-acting agents are ideal for our basal insulin role. So moving to the next slide. So you may be thinking, why would patients opt for an option besides rapid acting at mealtime and long acting for basal coverage if these combinations mimic normal physiologic insulin release? And the three most important reasons are going to be cost, number of injections, and the need for tight blood glucose control. So first, let's talk about cost. So the rapid and long-acting insulin options can be very expensive, whereas regular insulin, which is short-acting, and NPH, which is our intermediate insulin, are much cheaper, and they're even available over the counter. As for number of injections, if a patient opts for a rapid and long-acting insulin and eat 3 meals a day, then this could be up to 4 injections per day. Whereas some insulins can actually be in pre-mixed forms with this green plotted line here. So this would be less injections, and this is important for those that have difficulties giving injections, like elderly patients, or those that may work shifts that make it difficult for them to provide themselves multiple injections in a work shift. Also, I'm sure you can imagine that certain regimens may provide a tighter regulation of blood glucose, where others may be less so, but these others may come with an increased risk of hypoglycemia, which are all important factors to consider, especially with certain patient populations like geriatric patients. Now, regardless of which insulin combination you pick to provide basal and meal coverage, counseling for signs and symptoms of hypoglycemia and hyperglycemia will be incredibly important, as well as providing glucagon to patients when appropriate to deal with severe hypoglycemic episodes. So this may seem like a lot of insulins, but becoming more comfortable with the onset, peak, and duration of these different insulin classes, like our rapid, short, long, etc., is a great place to start familiarizing yourself with these agents. And this understanding will make this concept of combining different insulin types to mimic normal physiology easier. And we will revisit this topic and dive into much more depth in a video in Block 3 to reinforce this. So moving to our next slide. So in summary, I hope this video has showcased the importance of physiologic mimicking insulin regimens for type 1 diabetics and the different types of insulins available that can be combined to provide basal and mealtime coverage for a type 1 diabetic, making sure to take into account several very important patient-centered treatment factors like cost, number of injections, and the need for tight blood glucose control.